Hello, welcome to the Physio Matters podcast, this month in association with exerciseprescriber.com, and this is session 55. Hello, welcome back to the Physio Matters podcast. My name is Jack March. Unfortunately this month we've been having some technical issues, which means Jack Chew is unable to record the intro and outro as he normally would because he's attending a wedding. So you're stuck with me for this short period, but don't worry, his dulcet tones are all over the interview, so we'll get straight onto that. This month I'm going to take the opportunity to tell you a little bit about our Reforming MSK Practice Conference, which is coming up in October, the 5th and the 6th, with a little party in between. You can sign up already at reform.physio/conference. Go there, sign up for your ticket, sign up for the party, away you go. We've got some brilliant CPD. We've just released on Twitter the Day 1 conference program, and I'm just going to run you very briefly through that before we get to the podcast. So we are running things slightly differently. We're going to have a keynote lecture lasting roughly 30 minutes, which is going to be followed by a panel discussion. So for example, the first keynote session is on reforming our relationship with exercise, run by Erik Meira, who is our guest coincidentally on this podcast. He will then join Anne Gates and Brad Neal, where they will be grilled on a panel discussion. Then we'll be opening it up to the floor for questions from the audience. The following keynote will come then from Joletta Bolton, talking about reforming patient engagement. She will then discuss these things further with Pete Moore and Adrian McGregor. We're going to break for lunch with some discussions and breakout sessions, networking opportunities to discuss and go and do different things while we munch down on our sustenance to keep us going for the afternoon. Then we've got a brilliant session we've entitled the Agitation Session by Roy Lilly before we go into our breakout workshops. So we've got 3 of those run by Joost van Weechen, Paula Deacon and Brad Neal, which you can see on Twitter. Then we're going to go into the Day 1 debate after a break. We're going to talk all about reforming orthopedic triage. We've got an orthopedic surgeon, an MSK physician, some other healthcare professionals on that, where we're going to have a nice debate where we then open it again up to the floor. We're going to make everything super interactive, and hopefully it's going to be a much different conference to the things that you're used to. So like I say, go over to the web link, sign yourself up before all the tickets go, and we anticipate that these are going to sell out very, very quickly, and you can be attending that conference and getting some of the best CPD that we can come up with. So on to today's podcast. So we are, as I mentioned before, very lucky to have been joined by Erik Meira for this podcast, talking all things hips. So we're talking about younger hips, mostly to do with femoral acetabular impingement or its incarnations. You'll probably know Erik from his own podcasts that he runs. Our competitors, you might say, from across the pond. And hopefully we don't step on his toes too much and steal too many of his listeners. Wink, wink. Erik doesn't really need his own introductions, and this podcast is full, jam-packed of clinical information, really applicable straight away into clinic. You really won't need to digest too much of this. It's so well delivered by Erik, brilliant questions by Jack, and I certainly learned a heck of a lot from it. So I will see you on the other side for a little bit of a debrief, and hopefully you enjoy. See you on the other side.
Okay, so I'm delighted to be here today with a fellow podcaster, which is a bit bizarre. So we're gonna get confused as to who's interviewing who, I think, at some point in this. So forgive me if that happens. But I'm here with Erik Meira, and today we're going to talk about hip pathology, young hip pathology, femoral acetabular impingement, and as to whether or not we're going to stick with that term or not. But before I completely butcher his introduction, some of you, I'm sure, will be aware of him and his work and his podcast, which is our inferior American cousin, is how it's often known in the UK as PT Podcast. But yeah, Erik, as well as me just insulting you straight out the gates, would you like to introduce yourself to our listeners?
Yeah, absolutely. First, Jack, thanks for having me on. Yeah, my name is Erik Meira, and yes, I'm from the United States. I do have the podcast network, PT Podcast, which has a number of different shows on it. I've been doing that since I think we launched it late 2011. Otherwise, I am a clinic director of a private practice clinic that I own in the United States. And I am also a consultant with the University of Portland's athletic department. Been practicing for about 20 years or so. I think that about sums it up.
Yeah, I know, and lecturing both nationally and internationally. But I often see, whilst I've heard you talk about various different things and write about various different things on your blog and elsewhere, you do tend to seem to be talking lower limb more than upper. Is that a fair enough assessment?
Yeah, mostly, and most of what I teach is on hip and knee. My background is actually well, a little over 10 years ago, I started the hip special interest group here in the United States for physical therapists within the sports physical therapy section. It's just the way that our organizations are organized. So started that mostly because there wasn't enough information on young adult hip for those of us that are working in it. And so after doing my own bit of research, I just wanted there to be some sort of a clearinghouse. And so I kind of really got into collecting that information and then distilling that information through a special interest group, which Mike Raymond actually runs that group now here in the United States. But now my focus is probably more on knee pathology in particular, or knee pain, knee injuries. I do a lot with ACL reconstruction as well, but obviously pretty extensive background in hip.
Cool. No, that's great. So let's jump straight into it. I did mention it in the intro there about the fact that it's even a contentious term as I say it. I've supported a movement away from the term impingement, particularly at the shoulder. Are there any problems with this similarly named and increasingly popular diagnosis at the hip? And what's your sort of take on the term before we even get going?
Yeah, well, I mean, it's one of those that the consensus statement that came out in British Journal of Sports Medicine back in 2016, the Warwick Agreement, they changed the name, but only very slightly, from femoral acetabular impingement to femoral acetabular impingement syndrome, which I do appreciate adding the word syndrome in there. The problem. Kind of, as you're noting with the shoulder, the problem with the word, the term impingement is it has kind of a scary, sound to it. But the reality is impingement is normal in shoulders. I mean, you're always impinging by that definition. And it's similar in the hip. It's just where you're basically just in range and where that occurs. So, really, this is what it comes down to is, you can throw terms at patients. You just have to make sure you describe what they mean and explain how normal or abnormal they are, not just, scare the crap out of them and run them away. Our job is to define what things are. And I think that's where things can fall apart.
And so what are we getting at then? If we try to insult the intelligence of our listenership early doors in this podcast and think that they're not aware of this. So what are we getting at when we're talking about femoral acetabular impingement with or without the syndrome? What are we referring to?
So femoral acetabular impingement, it's exactly as the phrase describes. It's the femur and the acetabulum coming into contact, and there are things that can become impinged between those. Now, of course, as we talked about in the shoulder, when you raise your arm up, your humeral head and your acromion, generally make contact or at least squeeze structures in between them or impinge. You have a rotator cuff, you have a bursa, that kind of thing. So in the hip, it can be the labrum. There's some other structures in there, but typically they're talking about the labrum in particular. The easiest way to think of it is with, for example, the pincer style of impingement. It's where the acetabulum is, the easiest way to describe it is it's rotated in a way that it's kind of rotating over the top of the femur. Just in its natural resting state, it happens to be in that position. And so when the person tries to flex their hip, the femur is going to bang into the neck of the femur is going to bang into the acetabular rim earlier than would normally, and I use normal in quotes, on someone. Now, we've actually come to find out, and I think most people would agree at this point, that an isolated pincer type impingement, meaning the acetabulum has that orientation. Well, it's probably a very normal finding. That's rarely an issue in isolation. The cam impingement, which is the one that actually is what most people are talking about, I actually think impingement's probably not the best term for it because I'm trying not to get too far into it, but basically a cam is where the kind of ball-shaped head of the femur is more egg-shaped. So when it tries to turn inside of a, more spherical acetabulum, it creates a spreading type force inside that joint. So it ends up pushing on the joint wall, which can create some shear force, which can have an effect on the articular cartilage or push the labrum off of its root. So it's not so much that it, quote unquote, impinges as much as it just kind of gets shoved off the root. That seems to be more of a specific problematic type injury, which I will also debate whether that's truly problematic and how abnormal versus normal that is. But that is kind of the mechanism that's going on there.
So we're straight away talking about morphological changes, or morphological differences. Are these things at the hip natural physiological responses to load? And if so, how can we classify them with regards to, you're talking about abnormal, normal, adaptive, maladaptive. There's both, for me, the shapes, what determines the shape, and also then what determines whether or not those things become symptomatic. So we've got two fairly broad questions there. Take it where you wish.
Yeah, so, it's a good point. First off, we're talking morphology, not pathology. I'm always very clear on that when I'm describing CAM in particular. There are differences here, and so, nobody's femoral head is a ball, okay? Then it would be free floating. It has to at some point attach to a neck. How thick that neck is, specifically in certain areas, is what makes something kind of more of a cam. And there's a measure they use. It's called an alpha angle. It doesn't really matter, the specifics of the alpha angle as far as how it's measured. But it's interesting that people give it a cutoff of, say, like 55 degrees. Okay, so what if you have 56 degrees? Do you have a problem? And then the person with 54 degrees doesn't have a problem? It's not a dichotomous type thing. It's a spectrum. And of course, with any spectrum of presentation, you always have, a bell curve of presentation. So, there are people that, would have a 60-degree alpha angle that would be perfectly fine. There's somebody who could have a 50-degree alpha angle and they have a problem. The point being is it's always individual to the patient. As far as the load question, that's how these things form. We do know that they form basically at the physeal line on the anterior femoral neck. They seem to form, in males, more common in males than in females, but it seems to happen around the age of 12 years old or so somewhere around puberty. But we do have the problem of there are a lot of athletes who don't develop it, who had the same exposure to load, but they don't seem to get it. We have people in the general population with very little exposure to load that they have it as well. So we do think genetics definitely play a role here. You probably have to have a genetic predisposition, and then you have to have the loads applied to it. One of the problems we have, there's a lot of, speculation as to whether or not a sport like soccer or football, it definitely has a high prevalence of CAMs. But the problem is that people with CAMs also have a high prevalence of having basic retroversion of their hips, which gives them a natural toe out position, which may be an advantage for playing the game of soccer. So then you end up with selection bias issues, all these things. So, it all drops into the bucket of, what is normal, what is abnormal. And that's probably one of the hardest questions.
Yeah, and I suspect that you'll zoom in a little bit on that and therefore make it as individualized as possible. But whilst I know that work is messy and that literature is hard to tease out the detail, I imagine you have a sort of hunch take on whether or not you feel these things, these morphological changes and propensity to develop pathology. Do you feel that there is a link to training or overtraining of adolescents?
My personal feeling is I don't think it's I think it's a hard thing to say that And on that same note, when I look at all the potential benefits of involving an adolescent in sports, I think the potential benefits outweigh the risks, specifically regarding hip pain.
Yeah. Okay. No, that's fair point. Now, we've talked about a few of them, but what are the factors at play that result then in a symptomatic FAI or any hip-related groin pain? So we've talked about morphology. Let's point a little bit more at biomechanics, physiology, those sorts of variables, because we're talking about predisposition, but then what is it that then makes this a pathological issue?
So let's say somebody has a really big cam and they also have some retroversion of their acetabulum. So the acetabulum, instead of pointing slightly forward, it points to the side. Most people understand that, to the side and slightly forward. Instead of being to the side and slightly forward, let's say it's straight to the side. So the anterior wall is kind of closing off a little bit. So you got that, and you have a large cam. So when you go to flex your hip in a, quote, normal line of movement, say, let's say you're doing squat down, you're taking that cam, which is like a bump on the neck, and you're shoving it into the acetabulum in a position that actually a quote unquote normal hip wouldn't be entering in that spot, because they're in an unnatural position for them. And again, that's the thing, is it's specific for them. And so they end up putting a lot of shear stress into the joint. What the research has shown is that the thing that's most likely the pain generator in these situations, and that's what gives them that sharp kind of groin pain that's associated with it. And so, the simple reality of it, it really comes back to similar to like the shoulder issues people have. You poke at something, it gets hot and irritable. So now when you poke on it, it hurts. Right. You're poking on an irritated spot. That's really the long and the short of it.
So we're talking morphology, we're talking biomechanics, we're then talking about how that then might break down someone's physiological response to especially subchondral bone lesion of a sort, or a reaction, bony stress reaction of a sort. Obviously that needs to some degree, whilst again oversimplifying the complexity of a pain experience, but it needs to at least journey through the nervous system or pain as an emergent property of a human. So is your take that there is predispositions in those directions too? Because there's some people that seem to be asymptomatic that would, if under scan conditions, especially when we then developed the third Tesla MRIs, we saw a huge spike in what was being reported as pathology in not necessarily asymptomatic, but just people that happen to have some groin pain were then being misattributed sometimes to hip issues. So just talk in that direction if you can, as to what other variables are in play that then need to make that symptomatic to an individual.
Yeah, I like to cite Karen Briggs' paper from, I want to say 2012 now, where they just took a bunch of people that were around the age of 38 years old, threw them in a Tesla 3 MRI, and fired off images. People had no symptoms whatsoever, and about, I think it was 69% of them had evidence of labral pathology, labral tears. So, they're kind of everywhere, kind of like meniscus injuries or anything else. And so, I talked about, I focus a lot more on kind of knee pathology now. Most of the papers I've published recently have been on that, specific like patellofemoral pain. Patellofemoral pain, for example, has very high correlations with depression and anxiety. And so when we think of diagnoses that have typical comorbidities of depression and anxiety that create confounding factors, low back pain is what most people jump to pretty quickly as the kind of gold standard for that. And so I sometimes call patellofemoral pain the low back pain of the knee, shoulder impingement syndrome, whatever you want to call it, the shoulder, the low back pain of the shoulder. And I think femoral acetabular impingement can be like low back pain of the hip. And so being that, and whenever I teach a course, specifically talking about like physiotherapists, how many of you have had anterior knee pain in your life? And of course, like the bulk of the audience raises their hand. How many of you actually saw somebody about it? And most of them put their hand down. It's like, so when the patient is sitting in front of you, you could say their problem, the reason they're presenting to you today is because they have anterior knee pain. Or you could say the reason they're presenting to you today is because they can't seem to get past this anterior knee pain from a mental perspective. And so how much of this is just showing somebody that this is not dangerous, you're not doing damage, away you go. And that's actually what the quote unquote disease that you're dealing with is, not so much the physical thing that they're dealing with, but their education level, their emotional stance. What are all these other factors that can be at play? So I definitely think that this is a huge issue, specifically with hip pain, from a femoral acetabular impingement perspective.
And before I don't want to get stuck in the weeds with patellofemoral pain, but to be clear, we know that the sort of patellofemoral pain literature suggests that this isn't a self-resolving condition. You're not suggesting that they just happen to be sat in front of you and if left alone, they'd sort of get over it in time.
Nope.
You're just meaning that there's sometimes a complex set of social circumstances that make them bring it to your attention, and you need to be aware of those things, right?
Yeah. So, to give kind of an example there, so somebody's knee hurts and they go, oh man, I wonder what I'm doing to my knee. Oh, this is really troublesome. And so they rest it for a bit. It stops hurting them. And then as they go back to run again, their nervous system is like double and triple checking the knee to say, is it okay? Do you feel anything? You sure you don't feel anything? And you can almost create, you basically, to use a podcasting term, you put the gain a little too high in the microphone. So now all of a sudden they're much more susceptible to feel little sensations and interpret them as pain once they've kind of set that thing in motion. And so it doesn't resolve itself because they end up going down a spiral of, reinforcing their pain behavior. And then also from a tissue perspective, they're not putting load into that area anymore. So the area can become deconditioned and then hypersensitized as well. And so that's where I feel, intervention should be focused on with that. And so the intervention can be useful, but a lot of times just a matter of, because I've had patients come in and they're like, yeah, I've been told not to ignore pain. And so I want to make sure that this gets addressed. And when you say, no, actually, there's no damage really happening. If you can tolerate your activities, you're fine to just do what feels right to you. You do need to make the area stronger and be able to tolerate loads. But there's a lot of ways that you can get about that. And if you feel like you've got some tools on your own, knock yourself out.
Yeah, that makes sense. Now, whilst I don't necessarily like this as a generalized line of argument, I think it's interesting sort of manifestation of physio reasoning where people will, when they're thinking about the emotional aspects and the social aspects, then they'll sometimes then choose to think that, okay, that would mean someone might be holding tension through their shoulders, which might predispose them, therefore, biomechanically, because of different tonal changes of their periscapular musculature. Similarly, they might be tense through their, they're getting tension through their groin, and therefore they've got suboptimal biomechanics. So people immediately try to then reattribute it to biomechanical variables. And similarly, low back pain, I mean, that's the area in which has been obviously researched to high heaven, people assuming that people holding themselves too tense, and that's the direct cause of symptoms. But just to speak towards that a little bit, is there any evidence to suggest that whilst the specific morphology might not necessarily be the causal link, is there anything to suggest that people have a predisposition because of the way in which their sort of hip muscle imbalance is often the term used, or sort of a discrepancy between the length or strength of specifics, especially because there's the rotator cuff of the hip and the internal rotators, and people have their geeky anatomical answers for these issues. So just speak at that for a little sec.
The short answer is no, but you probably want me to elaborate.
You don't, maybe not need to. I like how much shorter your answer was than my question, though.
Yeah. It's pretty much no. And so, the problem we have, and I think this is, I can make a generalization to the profession as a whole, is we'll come up with these ideas, and then we'll implement a treatment approach to have an effect on it. So let's say, I think your muscles are really tight over here. So I'm going to do some sort of like a massage technique to release those muscles and to get them to relax. And then that's going to, make things drop into line a little better, and you'll have better alignment. Well, first off, you can't really assess the alignment anyway, even if you'd have to be firing off a bunch of x-rays and all that. But what they forget is that, when you do some sort of an intervention, there's a lot of other effects that can be at play. And that's what I always encourage people to do is, you can even, we can go back and forth all day as to whether or not I think somebody should even do a certain intervention at all. But what I would say to the average clinician out there is whatever you do to a patient, your brain's going to quickly go to an explanation as to what you think you just did. Challenge yourself to come up with alternative explanations of what may have been at play here. You don't even have to agree with them. You don't even have to change your mind. Just at least entertain the ideas. And so, one of those things I like to point out to patients, because they'll say, I've got to get my back muscles to relax. I'm so tensed up, and that's causing me all this pain. So I need the back muscles to get massaged. It's like, okay, look. The group of drugs called muscle relaxants, they don't go to your muscle and relax them. The muscle relaxant works by relaxing you. When you relax, everything kind of relaxes. So the point being is anything that makes you as an organism relax is probably going to have a pretty good effect on that general quote unquote tension you got going on there. And that's where, what I'll tell patients is, because they'll say, well, will massage help? It's like, yeah, I mean, you can go get a massage, but I think it should be a nice relaxing massage that you walk out of there feeling kind of loose and relaxed. It's not breaking anything up. It's not doing anything in particular. It's just relaxing. And this is where, things like somebody will go get acupuncture or something like that. Did it really realign your meridians and get your chi in order? I mean, I don't know, but what you did is laid down on a table for 30 minutes and had somebody focus all their attention on you while you relaxed, in a kind of quiet environment with no distractions. That potentially could be all that could be at play.
Because we're saying that there's a front-end mistake in a sense, or a front-end assumption that's being made diagnostically as to a causal link between a muscle tension, for example, we're talking about here. And then there's this sort of post-hoc justification of that intervention helped because it corrected for this fault. So in light of both of those things, you've not really got the sufficient evidence or reasoning to justify that sort of behaviour, and therefore to be, especially when some of these interventions are often uncomfortable, as you're mentioning, it's like, really, where's you're surely crossing a few ethical lines rather than just even one.
Yeah, and so, like, from my perspective, like, I don't provide any of those types of treatments. I put them all in the same bucket of whatever makes you feel better. I don't care. But they all pretty much, my explanation is that they probably all work with the same mechanism of just making the person feel more relaxed. It could be desensitizing, all these other things, but it doesn't really address any of the underlying issues unless their issue is, they have an anxiety disorder. So if somebody has an anxiety disorder and that's what's causing their problem, I mean, they can get all the massages on the face of the earth, all day long. It's not going to fix their anxiety disorder. It's just going to be a coping strategy. But the more that they believe that they need the massage to break up, tight muscles to allow them to move normally, then you create these weird dependence issues with somebody with an anxiety disorder. I think it's just, throwing gasoline on a fire. And, again, somebody goes to a psychologist with or a psychiatrist with an anxiety disorder. I don't think they say, go get a massage. That's not the treatment, okay? That's not how you treat an anxiety disorder. It's, you could also just drink a bunch of alcohol and, you're going to feel better for the time being, but that's sure not the right way to treat it.
Well, I'm going to cut you off there because that should be the answer to everything.
Okay, maybe it would.
Don't want to upset my go-to strategies. Now, we don't. I'm going to get back to treatment. Don't get me wrong, but I know how we got there. It was obviously part of the reasoning process and the mistakes that get made within the profession that attempt to drag back to biomechanical variables, even when we're talking about the effective. But before we do, then let's just go back to the start in a sense. In that, what are the subjective clues? And once you're suspicious of, say, FAI, what else should we ascertain at that point? So when we're first starting the exam.
So the first thing is the patient's going to report that their primary pain is in the anterior hip. So usually it can radiate down into the groin, but pretty much just right in front of the hip joint. They're going to point there, and I know Tom Bird was the first one to describe the C sign, which is where you put your hand in the shape of a C and then grab the side of your hip with your fingers digging into the front. And Tom actually recently pointed out that Kay Jones, his medical assistant, was the one that actually coined that term. But that's that classic symptom presentation of that there. And then usually they're going to have pain with deep flexion, internal rotation, and adduction across. And that's what you're looking for. And basically, if you think about it, what you're doing is taking a cam and you're shoving it into the acetabulum. And so you're taking a bulging area and a bony bulging area and pushing it into a sensitized region. And that's what gives them that pain. The other thing is typically someone with a cam, there's some research that has shown that there's a very high correlation with almost like you can basically say if somebody has less than 20 degrees of internal rotation, they probably have a cam of some sort, whether, even if they have no symptoms at all, they could just have a, quote unquote normal cam. So that's another thing that you can look for as well.
So they're describing these classic subjective clues. And then what else are we looking to ascertain in the subjective exam at that point when, let's say it is they're describing these textbook signs. But then we're going to go down the line of trying to understand, I imagine, let's say, their sort of loading profile and what they're getting up to. What sort of stuff are we wanting to detail for that when you're assessing someone?
Well, I mean, the work agreement did a really good job establishing the kind of evaluation process. They pointed out that the patient has to have a triad of things that they present with. So one being that they have to have that anterior hip pain. They have to have positive fader or a loss of internal rotation, meaning a lack of internal rotation. The fader being flexion, adduction, and internal rotation. When you stress them into that position, they have to have pain. And then they have to have X-ray or some sort of imaging to show that they actually have a cam in order for it to be diagnosed. And so the other half of it is, you have your hip mimickers, so things that would look like hip, and typically your athletic pubalgia would be one of those, and your psoas tendinopathies would be the other one, the other of the two main ones. And the problem with like athletic pubalgia is that it correlates very well with cam type morphology, but they won't have symptoms when you go into a fader. And then similarly, psoas tendinopathy shouldn't have symptoms when you go into fader as well, between those. But typically in the eval that I'm going to do is I'm going to look to see, how sensitive are they? So the fader is a very good tool for that. You put them into that position and you see, do they jump off your table, or are they just going to kind of go, yeah, that's the pain. And it's uncomfortable, but, I can tolerate it. There's different levels of that spectrum. And then, I basically look at their list of things that they're trying to get back to and trying to do. And, that's where I use my knowledge base to go, okay, well, I know these specific movements require you to go into those positions that cause you pain. So let's see if we can modify and go around that.
And so what sporting and worldly aggravating factors are they describing? Is it often quite general, or is it that they describe when I cut off this particular standing leg to turn left? What's sort of the generalized sort of go-to?
Well, interestingly, it's changed over the last 10 years. And part of that has to do with how quickly these patients are identified now. So that used to be that they weren't identified, they would kind of self-manage, and the ones that truly became problematic would have just really irritated joints. And so the typical complaint was they have pain when they get out of bed, or when they're getting their leg out of a car. So anytime they do like a straight leg raise type move, the engagement of the psoas pushes on that torn, damaged area and creates that kind of pain. Now, what it typically is they're going to have pain with deep squatting, and this is typically more the athletic people. So in their weight room doing deep squatting, or anything that requires them to go into internal rotation while going into a squatting type move. We've definitely seen it with like golfers on their lead leg when they kind of twist in an internal rotation really, really hard. Sometimes, sports that involve any sort of twisting towards the leg can create it. But usually it's squatting type movements is the bigger thing.
Yeah. Okay. So when we're thinking about the sort of descriptions of these symptoms, and they're changing over time because of how they've been picked up, and I think that's really interesting to have noted, and it's been a real sort of journey over time for various reasons with this pathology, and it is ever changing. Do the variables you're describing really influence your sort of, not diagnostics, but actually when they're describing the symptoms over the end of a soccer game? Although I'm upset that I've just used the word soccer, but I'll go with it.
I'm proud of you, Jack.
Yeah, cheers. And there's that, cumulatively they're uncomfortable through that, versus someone that's describing a sharp, intense pain off the back of a deep squat. Whilst diagnostically they come under the same umbrella as we're describing it, what relevance is that to? Are you just putting them into a box, or are you teasing out the differences between that, and that's going to indicate sort of complement your reasoning process to trying to help them to resolution?
Well, that's a really good question, because that is part of my thought process that, and I teach this in courses, is I always ask the patient, when did you first start noticing your symptoms? And so if they say, I first started noticing them in the weight room during deep squats, I had a coach that kept telling me I needed to get my toes straight ahead and go all the way heel to butt on my squats, and then my hip really started to bother me, and now it bothers me when I play my sport. That person, actually, I have a much I think they have a better prognosis for solving their problem conservatively, as opposed to the person who says, I first noticed it in the middle of a game during my sport. It actually doesn't really bother me in the weight room because I make adjustments and I'm doing just fine. But it's when I get out there and do my sport that's giving me the bigger problems. And that gets more into my belief that it's very difficult to change the way somebody is moving during their sport. I'm not saying it's completely impossible, but I would say it's essentially impossible. And so to me, that creates a little bigger of a problem for more that kind of quick fix, so to speak.
So you're suggesting that someone's complex sporting biomechanics that they've assumed over time, especially in, let's say, an athlete in their mid to late 20s, you're pessimistic as to how much we can influence those gross sort of sporting biomechanics, which makes you concerned that you've not got enough to symptom modify, enough to tinker with then there.
Right. And so, I mean, what I would try to do is, in that case, let's say they're a footballer and they were striking a ball, and right as they were striking it, somebody came in and hit their leg, and they really, on their plant leg, they really internally rotated really far, and they felt something in the front of their hip go, and now they've got this sharp hip pain in the front. Well, I'm going to shut them down, try to avoid those activities that irritate it. I'm going to put them in the weight room and try to keep them as strong as possible, maintain as much as I can in the meantime without aggravating anything. As it starts to calm down, keep them, building them up, and then start to slowly release them back to their activity and hope that it doesn't kind of flare back up at them. But if every time they go back specifically to their sport, it starts flaring up again, those are the ones I'm a little more nervous about. Because if the hot spot kind of calms down and then flares right back up again every time they go back to something, even though I've done everything else to maintain as much load tolerance as possible, those are the ones I'm more concerned about. Because I think a very complicated movement in sport, if it can be changed, it can't be changed quickly, and by quickly I mean within a year it can't be changed, in my opinion. And I mean, I could go on for hours about that whole concept. That gets into like dynamical systems theory and some of that type of and complex adaptive systems and all these things when we're actually talking about human movement. But that's where kind of more to your point, if an elite athlete moved like the average person, well, they wouldn't be elite now, would they? So why are you trying to make an elite athlete move quote unquote normal? What makes them elite is probably the fact that they do something a little unique and it gives them a special advantage in their sport. So the last thing I want to do is, especially when I'm dealing with very, very high level athletes, I am usually very wary to try to make any change to what they do.
Yeah. I mean, it's a funny sort of scientific. Well, if you call it scientific, because it's anti-scientific. But I mean, there's an arrogance that comes from expertise, or the perception of expertise, that people want to be very specific, and therefore, I think personally, it sort of carries with it this swagger where they're presented with a elite athlete, and they want to be presenting themselves as an elite therapist, and to do so is to describe an area of expertise that is something that's beyond the athlete's understanding, or still maps onto their understanding, and attributing specific causes to specific movements or biomechanical variables or sort of slow motion analysis. And whilst sometimes all of those things are essential some of the time, to do that and to rip someone's biomechanics apart, to quote Tim Westwood, very different character, Paul Westwood, who's been on this podcast.
Sure.
And obviously that maps onto people like Greg Lehman, Ben Cormack, who have also been on the show, that it's just tearing people down in that direction in order to, for what end, really, who's that for? Is that for the therapist or for the patient? And it is a concern, and you've certainly spoken really well in that direction. Like you said, we'd probably need more hours, wouldn't we, if we were going to go down that rabbit hole. So we're on to the question that whenever we do a pathology specific, shall we say, podcast like this, I always have to ask the question as to how special are the special tests in this region? Because we've mentioned some of them, and this is an area that if you call them special tests, then you could make a case, as Mike Ryman does, that there are certain sort of patterns or clusters of things that can be helpful. But he also writes that in a general sense that the special tests ain't that special. So what's your sort of take on it? What are your go-to things that you're looking for, and what do you actively avoid these days and have moved past?
Well, yeah, I joke about in the course I teach. I used to do a 2-day course on hip, and now I can't get more than 2/3 of a day on hip. It's just, there's just not that much there's not as much to talk about as we used to think. And so I used to have a list of like 15, 20 different special tests for the hip. And now it's pretty much all variations on the fader. And if you're going to learn one test, the fader is the one to learn. And so you just bring them up to 90 degrees of flexion. You push them over into horizontal adduction. And then you pull the foot out, keep the knee in to create internal rotation, and it should recreate their symptoms. Now, that said, that one test is very sensitive, not very specific. So in other words, if you do that test and it's positive, that doesn't really tell you very much. If you do the test and it's negative, you can be pretty sure this person does not have anything wrong with their hip joint. Or the pain is not coming from their hip joint, because it pretty much takes the hip and puts a ton of stress on the structures inside the hip. And so if the hip is irritable, it's going to hurt. The problem is it puts a ton of stress on structures in the hip that even a normal hip may feel some irritability to it. And so that's where, they're really useful for ruling it out, but not really useful for actually diagnosing. And I'm kind of a stickler for, again, that differential diagnostic process. You're always trying to rule out. You never try to rule in. You're just trying to show all the things that it isn't. And then once you've ruled everything out that you can, then see what's left. And if you only have one thing, then there's your diagnosis. But so that's why I do think they're very useful, specifically the fader, but not necessarily to rule anything in, just more to clear somebody out.
But you're not running an algorithm in your head then that's then helping to algorithm or flow chart, in the sense that you're sort of then in a situation where this is what this is and this is what we need to do next, and therefore this will clarify. You're building it into a reasoning process and framework that's not necessarily algorithmic by the sound of things.
No, and again, that algorithm is pretty much the work agreement's algorithm of the 3 things they have to have. So pain in the front of the joint, they have to have symptoms, which interestingly, it's like, yeah, symptoms, they have to have them. You can't just come with an MRI with a labral tear and say, I have a labral tear, it needs to be fixed. You have to have symptoms. So yeah, the symptoms, the findings on exam, and then the findings on radiograph. But the in the clinic, what I'm saying, the reason I go to do the fader is I'm asking myself, I wonder if their hip is irritable. And then I do that, and yeah, their hip is irritable, or no, it's not. I can't tell you how many times you do a fader and the patient goes, yeah, that hurts. Yeah, but does it hurt in the same way that of the pain that you're coming in here for. Oh, no, it hurts in a different way. Okay, well, that's probably something different. But that's really the only reason to do that test. It is kind of that whole, line of questioning of how long have you had your symptoms? How did your symptoms start? Were they in the weight room? Were they on the field? These types of questions. Where are your symptoms? Are you getting any mechanical type signs? Let's see if your hip is irritable. Again, how long you've been dealing with, anything that's less than 3 months old, I probably want to kind of ride it out, see what it's going to do on its own. Things that have been going on for a year or so, I'm really starting to question why the body didn't just kind of figure this out. And I'm probably going to be leaning more towards getting a radiograph just to give me a little more information. But all of that weighs at all times.
Sure. Now, we want to take a deep dive into treatment options, but it'd be too easy for us to walk through the sort of conservative loading-based variables that we will get to, but it'd be almost the low-hanging fruit for us. I think we'll get us teeth into it. So to make sure we don't end up squeezing them out of time, I just want to go back to one of the examples that you used about a person that's sort of developing, no matter how you reload them back into their sporting context, it's starting to get sore. I just want to talk about the physiology of that and therefore how that might indicate different treatment options. Do you feel that is potentially worsening their structural issue and their sort of anatomy and physiological changes at the hip? Because that's often the concern that people are having as to when to draw the line under when physios. Obviously, you hope you'd be working alongside a surgical team, perhaps in an ideal world, but it seldom happens. So instead, people are often worried that they are truly worsening someone's arthritic process, for want of a better term. And so, what's your take on what's going on there? How cautious we might need to be in those circumstances?
Well, and when I teach this, I'll show the process of how a cam causes articular damage, and it causes a delamination injury of the articular cartilage, and it looks nasty. I mean, it is big, massive chondral flap that gets ripped open. It's it keep you up at night if you look at it. But that said, if you talk to the surgeons, what they talk about is if they get in there and they see this chondral flap on the acetabular side, which is typically what you'll see, they don't get real worried about it. They just debride that away. They shave the cam down so it stops poking on that. And that's all the surgery does. The surgery is a decompression procedure. You're having pain when this bony bump pushes against this thing here. So I'm going to shave the bump down so it doesn't push on that anymore to allow it to calm down, because everything else we've tried to calm it down isn't working. So we're going to physically remove the offending thing that's poking on that spot. Somebody can learn to tolerate that being poked through progressive, loading to that, but some people, it just doesn't work, and so they'll shave that down. Now, what they say is that's all stuff they can fix, and they usually will see a pretty good prognosis. But if the chondral lesion is on the femoral side, which is rare, that's more an indication of this thing is heading down a bad direction and you're actually going towards osteoarthritis. And that's probably what you see as early signs of osteoarthritis. To me, that chondral lesion that forms on the acetabular side, because it seems to form so quickly and so easily, I start to feel like this might be something that we're kind of evolved to have. That's like our circuit breaker type thing that kind of gives. And then once that chondral area kind of gets torn away, it gives you a little more space in that joint. And then the pathology may not progress any further than that, for all we know. Research shows that people can live pretty long without any sort of real hip problems, with pretty big cams. And, they talk about this alpha angle really needing to be up over 70 degrees, which is a massive alpha angle for there to be any real consistent problems. And so, how much is this just the body going through some adaptations? You let it calm back down and then it's perfectly fine. That's I think, okay. So again, to your point of that patient has this process going on, it all comes down to what they can tolerate, what they can't tolerate. I mean, even somebody with full-blown OA, you don't say stop your activities because you're going to ruin your joint. You say do what you can tolerate. It is what it is. If you're really kind of destroying that joint, it's hard to push through that kind of pain, unless you're, taking a bunch of painkillers at the same time. So I just don't think the body allows itself to get broken down quite like that.
Yeah, I don't know. I think that might be a fun point of subtle disagreement, unless I'm being pedantic, because I think I wonder if you perhaps, I mean, in that circumstance, it would be that you're suggesting that the pain is a particularly useful and accurate measure of damage there, aren't you?
No, more kind of saying it's again kind of like that sensitivity specificity thing. So if you're feeling no pain, I doubt that I'm pretty confident to say you're not really having anything, quote, harmful going on. On the flip side, just because you feel pain doesn't mean it doesn't mean that damage is happening. But I think in order for there to be anything significant to be worried about, you have to have pain with it. But just because you have pain doesn't mean that something significant and damaging is actually going on. And then again, as we talked about before, how somebody interprets that pain, how somebody's nervous system could be amplifying pain. I'm not sure, there are definitely, cases where people don't feel pain and the horrible lives that they actually lead, but those people are very rare and typically not the person that we're dealing with.
So it'd be the real tails of the distribution for us to be thinking about, like the people that come in that have got really advanced changes and have just developed a bit of stiffness, or only come in when they can't tie their shoelaces. I mean, which unfortunately we do see, but yeah, we can't pretend that they're representative. They're an interesting example to use when we're talking about the complexities of pain and it not correlating. But we're also got to admit that they are on the rarer side. But if I were to just talk about that what we often the term is used in the UK at least is this fraying process that occurs at the anterior labrum. What I just want to talk about is that justification, this description of what you've described as the pathology or the worsening of it, especially from a CAM issue, is often the justification that people do to treat asymptomatic hips that have been discovered to have this issue as a means of stopping them developing pathology. What's your take on that as a prophylactic process of surgery? Because they perceive that is to stop an inevitable wrong that will occur down the road.
I don't think there's any evidence for that, and honestly, I think that the hip joint, the reason we haven't been in the hip joint arthroscopically until relatively recently is because it's a very difficult joint to get into, and it's very easy to do harm when you go in there. It's very, very easy to do harm, and you're probably more likely to do more damage than you will fix there. And again, that kind of morphology, the idea of it being pathology, I think is, dubious at best. And so, I highly recommend against that type of thing because, that there is some research looking out longitudinally, actually it's more looking like generationally. People develop CAMs. There is some correlation whether or not the CAM was developed in youth versus it being an actual more of a bone spur as a reaction to osteoarthritis. So it's hard to say, chicken and egg, that type of thing. That it's just really hard to make those types of statements. And I just can't see that as being a thing. And again, for some athletes, I think it may actually be an advantage to have it. I think, one thing it does provide is a lot of stability in their hips. And we do see a much higher prevalence of it in athletes than we do in the general population. And so I wonder if it's something that they kind of use. So I mean, full disclosure, I've got a CAM on my left hip at least. That's the one I had x-rays just to see what I had. And I'm sure as hell not going to do anything about it. The surgeon I work with, that's our main hip surgeon, he's got a CAM on one of his hips, and he doesn't do anything about it. He thinks it's perfectly fine. Just leave it alone.
I'm now not going to sleep because I'm worried about both of you. So
we're a disaster.
I wish you hadn't told me that. I'm pretty scared for you. Now, there's lots of different treatments and surgery. There's lots of different types of surgery. It's a very experimental area. It's annoying. We can't call it new really at this stage, but it's still something that's being played around with now. And it's also a place that not just surgery, but the general regenerative medicine sort of crowd are very involved in this. And so Before we get again into the more conservative-based interventions, can we talk about where you feel there is and isn't evidence for, let's say, types of surgery, injectables? Are you someone that's on the stem cell wagon? Where's your head at with that stuff?
Yeah, I don't think the injectables really probably do very much. I mean, what most surgeons will use a simple pain injection, so they just guide a needle into the hip joint, hit it with some sort of anesthetic just to see if they numb the joint, do the symptoms go away, and that gives them pretty good sense of where the pain's coming from as far as the joint or not. They also, so a diagnostic hip injection, but they also talk about how the patients will want surgery so bad that they'll tell you it felt better, whether it felt better or not, which can really, confound things as well. But again, I think that the simple goal of surgery, if somebody were to go to, is to decompress the area so it doesn't cause pain and dysfunction anymore. And so again, back to the point of people trying to do it prophylactically, if it's for pain and dysfunction, why would you use it when there's no pain and dysfunction? And so this is where that's really the only goal of that surgery. Now, they do reattach the labrum mainly because they can, and why wouldn't they? It's no more difficult than any other part of the surgery, so most surgeons will do that. But also, there was a run for a while where if the labrum was destroyed and they couldn't repair it, that they would reconstruct it like with a piece of a hamstring tendon. That's fallen out of favor because you just trim it away. I don't know how quote necessary that labrum really is. And so that's really the long and the short of it, is just keeping it simple of, they're not tolerating that thing poking on them anymore. You've done everything you can with activity modification and it's not making a difference. So, go ahead and just decompress it and then do your rehab all over again.
See if they can adapt this time out. I don't know again if it's popular across the pond, but certainly microfrac at that area where they're trying to stimulate physiological recovery and things like that is still very popular in and around the area. What's your take on that?
Yeah, well, microfracture does not have, if you look at the meta-analyses and systematic reviews, doesn't have a really good outcome in general, pretty much any joint. Most surgeons, they still use it at the hip specifically because they don't have any other option in there. It's such a deep joint. It's, you can't do any sort of a transplant or anything like that really without doing a massive opening of the area. And so they just go ahead and microfracture it more out of a why not type perspective. I have had surgeons that I've talked to that have said that you could probably just leave it as is, just to breed the damaged cartilage. There's plenty of evidence that cartilage is not going to heal. It's not going to heal back down. It's not going to do anything. That articular cartilage is damaged, just to breed it off, do your chondroplasty. And then you can just leave that area as is. The problem is not that the area is there, is that the area is getting poked by the cam. And so it's easier just to take the cam down than to try to get that area to quote heal, as far as grow new cartilage over it, whether it's fibrocartilage from the microfracture or any other type of procedure. The idea is just stop poking at it.
Yeah, no, fair enough. Now, so we've also ascertained that you're not into the injectables, which mean that you're probably not on board the sort of stem cell revolution. Partly because you're not feeling that it wouldn't decompress the area, it wouldn't actually add much to it, because you don't think that the physiological changes are the be all and end all. Is that a fair assessment of your take on those things?
Yeah, so stem cell is a very, very interesting field that probably has some promise to it, but it's in such an infancy that you're basically just throwing randomness into a joint, which I think is just not a good idea at this point. And again, as you're noting, that area doesn't need to quote heal, it just needs to calm down. And these things are not really going to do that. I mean, weirdly, I would actually think I could make a better case for injecting a steroid into the joint as a one-time injection just to force it to calm down. I wouldn't do more than one injection though, just once, see if that could knock it down, and then it stays down on its own. But no other thing really, would I argue for. as far as injectables.
That's great. So we can get into the good stuff then. So let's talk a little bit about rehab. Let's say that we've got someone that is quite sensitive and irritable, and therefore not currently playing sport, very tentatively and nervously trying to do some exercise but not a lot. What's your sort of go-to strategy in the early stages when it's sort of really revved up?
Well, it's really complicated. I don't poke at it. So whatever positions are causing the pain, we just avoid those for the time being. I think where a lot of physios get it wrong is they decide, well, those positions cause pain, therefore those positions are bad and should be avoided forever. It's not how that works. It's irritable, leave it alone for the time being. So we just try to avoid those positions as much as possible. Again, as I talked about before, most patients, their difficulty is in squatting. That's what's causing their pain. So I try to get them squatting as early as possible in a pain-free way. The most basic one I can throw at somebody is put a physio ball behind their back on the wall, and they do wall squats. But the point of doing the wall squat is so that they can get into whatever unnatural position they feel like they need to get into to make their hip feel good squatting. That's typically kind of splayed out, hips kind of externally rotated and abducted as they go into a squat. Usually that will feel really comfortable for them. So I just want them to get lots of exposure to squatting that's pain-free. And then progressively bring them into more natural type movements. Typically when we start adding load to the hip, to a squat, we're going to go with a trap bar squat. So the trap bar, that device that's hexagonal shaped that they step inside of, it's got handles on it, and you can put weight on the sides. Anecdotally, pretty much every hip patient will get in there and be able to find a comfortable position pretty fast, and away they go. And so like our higher level athletes, on day one, if they can do trap bar squat, we're going to put them with a trap bar, and I'm just going to start putting as much weight as I can on there to really try to tax them out and maintain their squatting strength.
And so your trap bar rationale is because you've got more degrees of freedom to play around. They can be a bit more creative than they can on a sort of barbell squat across their back. Exactly
right. And I don't comment on their squat mechanics at all, other than making suggestions as to, maybe if you try it, if they do the squat and they say that still hurts, so we'll maybe try doing this, typically splaying the leg out a little further. That's the commentary. Or if they go to lift the bar and they do it in such a way that makes me almost vomit because it's so weirdly, rounded in some horrible way, I'm like, okay, maybe flatten that out a little bit. But otherwise, whatever is making them feel comfortable, I just want them to get reps of pain, minimal pain squatting.
Okay, and then we're going from there then. So we're exploring and doing these heretic-like unsymmetrical squatting. So once we've done that and we've thrown the textbook out the window, where we're going in terms of, is there any other really specific stuff that you'd want to phase in, or does it become more specific purely based on function as we go through the gears?
Yeah. So what I'm trying to do is, I typically, if when I evaluate them, they do a squat and it causes pain. The first question I have to ask is, the way that they're squatting, is that a way they have to squat? So for example, a hockey goalie having to drop down into a position like that, a baseball catcher has to be squatted down in a very specific position. It could even be a snowboarder that when they land from a jump, their foot, because of the orientation of their foot on the board, it drives their knee up into their hip like that, and it's a position they have to get into. Then I'm going to have to slowly progress them towards that task again, and I just try to recreate the basic positions, because I think this is more of a positional issue than it is anything else. But if it's strictly because the only time I ever need to go into that squat position is when my strength coach tells me to do that, I just call the strength coach and say, don't do that anymore. And it's a simple solution right there. And so again, is it specific to the task? And so what we just try to do is just maintain their kind of comprehensive strength in general. I don't know what's normal for this athlete. I just want everything to be as strong as possible. So just a comprehensive program, making sure the quads are strong, hamstrings are strong, glutes, low back, everything else, just comprehensively making sure everything stays strong and trying to avoid those painful positions for the time being. and then have them start kind of going back into their sport type activities. Now, we can try to recreate some of the loads of sport to see if they can tolerate those loads, but we can't actually recreate the sport in clinic. And that's because sport, like any other human task, has a lot of, psychological factors into it, like representativeness, the specifics of distraction, even like the smells of the field. These types of things all create a very high specificity to the task, that they really have to get back into that environment for their body to go back into its kind of normal pattern. And so we just try to do like a systematic return to activities where we just, kind of widen the circle of what we allow them to do and allow them to explore, but we don't really drive it very much. We just kind of see how the organism organizes on its own.
Yeah. Now we've already anticipated. Well, we've already spoken about in the chat so far about how sometimes it takes for a real careful reloading process and phased return, and that it sometimes takes a bit of wash, rinse, repeat, and a trial and error as we're getting through that. Do you have any go-to sort of positions or tactics or strategies to phase someone back into those sorts of tasks that are famously aggravating? So do you have a sort of a go-to phased thing that you can tweak the dials on gently?
No, I mean, it really is just a matter of going from the position that we found that's comfortable and then slowly moving them towards the position that's known to be uncomfortable. For example, we mentioned patellofemoral pain before. We'll avoid valgus temporarily because that's known to put more contact pressure on the patellofemoral joint. But as it starts to feel better, if there are tasks that they do require valgus, we'll have to start progressively loading them into the valgus. But we just use pain tolerance as the guide. So, keep it within tolerable pain. And of course, people like to ask, so give it a number on 0 to 10. It's like, well, if you can stay strong through it, it's tolerable. If when you feel the pain, you feel your body kind of go weak a little bit, that's not tolerable. That's probably the most practical view to that.
Like a pseudo giving way of a sorts where it starts to feel
exactly. That's the body's natural kind of protective mechanism.
Break phenomena. Yeah, no, I like that. Now, there is just to press you on that a little bit. If we were to, because there's variables in play such as, let's say, depth of range, speed, amount, sets and reps. There's lots of variables there that are still part of a phased return package. Do you have a favoured preference there? So I'll put my cards on the table and say that for some reason, and it's not always a healthy one, speed tends to be something that I bring in later. I mean, I'm trying to couple this with a generic phase return to the actual task. So typically I'm hoping that speed comes for the ride on that. But certainly with my programming, I'm going fairly heavy, fairly slow, going through the grades of resistance, adding more repetitions, and then bringing speed in. And again, I'm not saying it's a good habit, but I'm admitting that it's a habit of mine. Do you have any sort of favoured preferences for that, or are you have you corrected for my bad habits already, and you get speed involved as soon as you can, and you're doing it all at the same time?
For these patients, I don't worry about it too much. The hip has a tendency to kind of organize itself pretty well. For the knee, on the other hand, I think speed specifically, not to get too pedantic, but you have power, you have rate of force development, you have all these other variables, how, what kind of effect on impulse, these types of things when you get into this. But really, speed is a component of force. The Newton's second law of force is mass times acceleration. So when you start to ask somebody to move quickly, you make them move at a higher velocity. And then when you ask them to change that velocity, that creates a deceleration. The faster you change that velocity, so the more of a quick type movement it is, or change, that creates a higher force because your acceleration part of that equation goes up. Mass isn't going to change, but the acceleration does. Or deceleration, vectors don't care for positive, negative. So that is a force that may be much higher than what you worked at a slow speed. Now you can also work at a slow speed at a much higher load, and so your tendinopathy experts will talk about this, where they get to these really heavy loads at slow speeds and then bring that load way down and add speed, which should be creating an impulse similar to the slow loads that you're applying as well. So it is kind of that, incorporating all that in there. Now, the nervous system has to be able to adapt to speed as well. And again, this is where, at the hip, everything is always at play, but I just don't see it as big as a factor as we see like in postoperative knees, the ability of the quadricep, not just to generate force, but to generate it at the adequate rate is a huge issue that I think way too many physiotherapists are completely ignorant of. It's not a question of how much force they can generate. It's how much force can they generate in 0.3 of a second. If they can't generate the force in 0.3 of a second, you can't generate the force, full stop. And that's the issue. And so, again, not so much at the hip, but definitely
we have to be less fussy than that. We can be less fussy than that at the hip, so that's promising. And as I suspected, I need to just get out of that habit a little bit myself. So that's really interesting. Now, what variables are you measuring or monitoring at the end stage of rehab when you're in that return to play? What are you asking them to keep an eye on, or are you just wanting them to move in a movement liberated way at that point, and you're just really only bothered about their symptomology again if they're getting sore, or are you keeping an eye on any particulars?
It really is that soreness. And so what I'll tell them to do is, hey, everything's been feeling really good in the weight room. You don't feel it in your daily your activities of daily living. You're not reporting any sort of symptoms with that. We've been pain free for a week, 2 weeks. Again, depends on the level. Like really high level athletes, man, you've been pain free for a week. Let's start testing it because we got to get you back. We let them go mess around on the field a little bit. If they're a footballer, go ahead and, start kicking a ball around the field. Just mess around by yourself, take a couple shots on goal, and then report back. And they say, man, everything felt fine. Great. Or, every time I went to my left and made this very specific move, I felt pain there. And then I'll look and I go, oh, well, because that puts you into that position again. So maybe avoid that for right now, but do all your other tasks for the time being, and we'll come back to that one later. Again, just letting time be our friend and letting it kind of help us along with that. But very much just, again, with this type of thing in particular, I think it's very much position specific and just coaching them along as to letting them understand what positions will tend to aggravate it versus which ones won't.
Yeah, and so you're probably, whilst you're caring about cumulative loads and bearing that in mind in your reasoning process, you're not immediately strapping a GPS to every one of these athletes to make sure that you're monitoring specifics of the metrics and the data that they're then collecting for, or even any specifics with wearables on force production and things. You're not wanting to tinker with those variables at that stage, by the sound of things.
No. And the big issue is, as you talked about the tails, the bell curve, so what's normal for this person right in front of me? The best way for me to establish that, let them just kind of go out and mess around with that. Now, if I have all the technology and I can gather those data, I could potentially be able to see, I can tell, he started reporting symptoms at this point here. So here's the level of that. But I could also just tell them when you start to feel symptoms, back off. That's a lot simpler way to do that. So it's really a question of what resources do you have, what is expected out of you as a professional, as opposed to what is actually required. Again, kind of that 80-20 rule. What's the 20% of work that'll give you 80% of the results? Make sure you're taking care of those things.
Yeah, no, keep it simple. Like it. That's great. Now, you did briefly mention it. Well, it's kind of come through the entirety of the process, is that timing both of symptom onset, but also then we need to think about what sort of time frames are we expecting these sorts of results in. Whilst I know that is obviously as individualized as the rest of it, could you give us any sort of clues as to what your typical spiel would be for people that are coming in terms of helping them to understand what is required of them in terms of timeframes? Because we also don't want to over-egg it. You don't want to tell people that, strap yourself in for a 3 to 6 month process and they come back in a couple of weeks later with their eyes rolling saying, what on earth did you scare the hell out of me for? I'm feeling loads better already. We want to try and make sure that our prognosis isn't a million miles away. So how do you best mitigate those factors?
Again, it depends, as with everything, depends specifically on the circumstances of the patient. So, a high-level athlete that has a very short timeline to earn a living and needs to get back as fast as possible, we're going to be guiding them a little differently than the person who says, no matter how bad this gets, I'm not going to a surgeon ever. Even if I have to live in a wheelchair, I'd rather that than surgery. You're going to treat them differently as well. But typically what I like to do, and this is pretty much with any diagnosis, I want to see you for 2 weeks, and something should be changing in those 2 weeks. There should be an immediate effect of some sort. So I've taught you how to avoid the positions that typically aggravate this, and that's making a difference. If it's not, then I usually want to pull in a consult from outside to take a little closer look at this and try to see. As I mentioned before, if it's ragingly bad, everything hurts, they have sharp pain all the time, they're just miserable. Sometimes, a steroid injection just to force the thing to calm down, give them a break, can be helpful if nothing else is working. But, for the most part, I usually want to see some sort of change and feel like that patient already has control over their symptoms, meaning that they can make modifications to reduce it within 2 weeks. I want to see that happening. Now, as far as like the long-term prognosis, what I will usually tell people is, even when everything is said and done, I mean, with most patients, they come in with some pain, you give them some stuff to work on, they start working on it, they start feeling better. Once they hit a certain point of feeling better, they kind of stop doing what they're, quote, supposed to be doing. And the pain never really goes away, but it's just kind of there and it doesn't really bother them anymore. Some people see that as like a moral failure of you didn't finish out the program. It's like, no, the patient just does whatever. This is in service of the patient. So if it works for them, it works for them. And so, I'll tell people, even when this is all said and done and you don't have any pain during activities, you'll probably be able to make it hurt if you wanted to. You get into that fader position and really ream on it, it's probably not going to feel that great. Does that mean you're not, quote, healed? No. As I tell people, right now, the amount of load it takes to cause irritation is here, and I'll put my hand at a position. We're just trying to push that up as high as possible. We're not trying to get rid of it, because that doesn't matter. Just push it up as high as possible so that in order for you to feel pain, you got to put some insane amount of load into it to make it hurt. So that timeline, as long as they're getting better, I don't really care how long that timeline goes, and it can go as long as, is acceptable to the patient. But for the most part, our higher level athletes, I want to be getting them back to sport activities within 6 weeks of initial visit.
And I think people underestimate just how many of these things top athletes and even quality amateur athletes are carrying these issues. They're functioning with them, and how far they then take it and how much they aspire to be pain-free in that direction is up to them. I mean, what are people calling for? Mandatory training camps and rehab camps in which there's sort of they need to be making sure they take themselves into the end zone of 95 to 100%, even if they're not really that bothered and it's not interfering with their abilities. I think that's an important point for people that people do sometimes miss. It isn't a failure. It's completely an athlete's prerogative to do that if they wish. It is their body.
I have a funny story for you on that line. I work with a college sports program, and we had a couple of baseball pitchers. Baseball pitchers notorious for kind of chewing up their shoulders. And we had this kid that, he just has a shoulder pain. And every time he throws and, a certain thing, his shoulder just hurts in a very specific way. And no matter what you throw at him, you test him, he's got a lot of strength, everything looks good. And so he's in the training room, which is where the athletic trainers here in the U.S., it's kind of like the sports medicine room at the university where all the athletes, they come there if they want to throw an ice pack on their knee or if they just want to get some medication because they have a head cold or something like that. And so this kid is in there because of his shoulder, and one of the other pitchers walks by and goes, "Hey, what's going on?" And the kid goes, I just get this pain in my shoulder when after I throw," and lay out all the symptoms. And the other pitcher goes, "Oh yeah, I get that." Like, so what do you do about it? "Oh, I just ignore it and just keep doing my thing and it's fine." And so it's like, yeah, how much, this is that medicalization of things is this just something you just need to kind of, I think as you guys in the UK say, just crack on, or is it something that you really need to do something about?
And it is, I think, on those points, and obviously we can go across the body on this, really, is that how people have decided to perceive that, how that maps onto their sense of self, and what they think is the consequence of them ignoring it or cracking on. And so for those two people, let's, for the sake of argument, even though it's ridiculous to suggest it, let's imagine that if we could find a way to objectify their pain experience, it was identical. It's just that the way in which that mapped onto their sort of being was different. If we're doing that, isn't it amazing how it must be something to do, you would think that it would be something, or at least it's my bias to think that it's something to do with what each of them thinks the consequences of inaction, or the reward that might be that's coming through the system of going through the motion.
Oh, and we can go into so many things like loss aversion and all these psychological constructs that people have that drive them towards certain behaviors that, it becomes so deep and convoluted that, there's a lot of play.
Well, we've got a lot. It's and I don't know if this plays out as well, but it's I think it's a fair thing to be talking about it on this podcast about this particular pathology, because I've had a few that really ring this bell. But it's like these athletes that are coming through, especially young lads coming through that are, especially in the semi-professional academy, sort of they're on the cusp of they thought they were going to be a professional football player. I'm going to football again. Sorry, mate, but yeah, I think we'll stick with that now. But it's they'd never declare it, and I also don't know if they could articulate it if they wanted to. It's not as if they'd been deceptive, but they'd rather suggest they're not making it because of injury rather than not. They're on that cusp of it. Are they quite good enough, especially in a very, very pressured environment? And so they capitulate it to them because of injury, be that hip or otherwise. And realistically, is it that, or is it just the fact that they were in that situation where they didn't quite make it? And that is a really awkward grey area. It's not especially politically correct, because you're sort of inferring that they don't. It's almost like you're suggesting they're not being honest, but I'm not meaning that they're doing it consciously. I just think it's a messy grey area. There's a lot of pressure on these athletes, and so really that they just feel like it's a better thing to have had to bow out because their body gave up because they worked it too hard, especially then if they've got physios and other professionals feeding in the fact that, we've got this evidence to suggest that you probably overtrained, and he'll go, that'll be it. I overtrained, I've worn myself out, and here I am. And I'm
pushing myself too hard. I work too much. We have a saying in the sports medicine world of nothing fixes injuries like winning. If they're winning, they're like, oh, no, I'm good. And they'll push through injuries so much harder. But if they're having a losing season, they're just like, why am I pushing through this? I hurt. And so I don't want to play.
Absolutely, and there's amazing amounts of data that we have over that sort of stuff, don't we? Where the body mapping stuff, where people have just done tenderness readings, haven't they, on the winning and losing teams and stuff like that. And then there's really good stuff that always crops up around World Cup time, where people have done the same sorts of tests on the fans, and then and obviously that maps onto public health stuff as well, like the amount of heart attacks that happen on stressful games and all sorts of stuff like that. I think we're wrapping up the FAI stuff, and it brings me to just want to talk to you a little bit about we're getting you over into the UK. I know you've visited a few times, you've run some courses over here, but we're getting you over as one of the keynote speakers at the Reforming MSK Practice Conference in October. And so as long as, you might not want me to say this publicly, but you kindly reached out to me when you saw that we'd launched the Big R's Reasoning Responsibility Reform process. You reached out to me and sort of suggested that you were a supporter and fan of what we were doing with that. Can I just, if you now that I've just outed you as a fan of the movement, do you mind telling me as to why you felt that you think it's a good process, and then we'll talk a little bit about what you're going to do for the conference?
Well, I like the fact that you're the kind of the goals of it to kind of open up the conversation to expose it. I'm a big fan of kind of freedom of speech, that good ideas, if presented eloquently and fairly and rationally, the best ideas should, there's a little bit of a meritocracy there. The best ideas should kind of present themselves. And, when you have conversations, it's like when you sit around and have a couple beers with some people, you have the conversation. It's like, man, we got all the solutions here. Why can't these solutions be implemented? Because a lot of times it's not that complicated. It's some pretty simple things. Once you get people kind of to all get on that same page of, where can we, find alliances and common ground on some of these things, and then move forward on making those changes. Because, again, people will start, nitpicking off in the corners, and it's like, okay, well, not that those aren't valid discussions to have, but let's look at some of these kind of big ideas and see if we can really try to move things forward. So I like the fact that you're getting the people together, and then also that you kind of, come out of it with a little bit of an action plan of this is what, we should be trying to do here. And I just I like having those conversations, as I talked about before, like when a treatment quote works, why? What are all the myriad ways that this could be working, and how can we make ourselves better through having a deeper understanding, instead of just shrugging our shoulders and saying, this is the way I've always done it, and I'm going to keep doing it that way. So I like this attempt that you guys are having.
Lovely. No, that's great, and I'm glad that you've noticed that from our messaging, because it's been part of the backlash that we've received from causing a stir in that direction. Is that for you to have noticed that, and I've not prepped you for that. That's how you've read what we're doing, which is pretty accurate for me. That feels like a fair representation, and not as if you're being excessively charitable.
Yeah, and there's some things that are definitely up for discussion. There's personal preference, there's opinions, these types of things. But then there are also like things that we can look at from a very objective perspective to say, no, we can pretty much, the example I always give when I have a lecture I do just on the scientific process, there's not a lot of debate there as to whether or not the sun goes around the earth or the earth goes around the sun. We can find conclusive evidence of certain things, but then there are, life circumstances of, if you grew up, poor, of a certain ethnic group in a certain part of a country, your quote reality will be different than somebody else's reality, and there are cultural and personal experiences that can change things. And so, trying to find where we can come to the common ground on those kind of objective truths that are kind of hard to argue, and then allow everything else to exist around that.
Absolutely. No, and you've totally nailed what we're trying to do is mapping where, making sure that all the voices are heard, people that want to lean towards the objective or objectifying most things versus the people that want to talk about the specifics in a relativistic way about the subjective experiences and how they might manifest. Let's get all the voices together to try and work out where they overlap, and also trying to bake in room for those disagreements. The distinctions aren't irrelevant. We're not trying to homogenize everything, but it's like, what can we agree on, and then how can we create a system, a blueprint of practice, of a gold standard of sort of way in which we're doing things to drive both the profession and the industry forward, which is why we're calling it Reforming MSK Practice. One of the things that the listeners will hopefully know of you, or certainly will do when they then go and hunt down some of your resources after this, if this is their first encounter with you, is that whilst we've zoomed in on a particular pathology today, you're very much a polymath in the MSK space. You talk about reasoning, you talk about the scientific method, you, as you've just said there, trying to discuss subjective and objective variables without being dogmatic or ideological in either of those directions. For that reason, we wanted you to come over as a keynote speaker, and we're giving you as broad a scope as we can on the topic of exercise, in which you're going to do a keynote for 20 minutes. We're then going to come on, me or one of the team will come on and grill you for 10 minutes, sit you amongst a panel of other people who are known to be vocal in the direction of exercise for various things, and then a big Q&A to bring that session to a close. Just give us a few clues as to what sort of stuff people might expect in that session from you.
Well, I mean, the big thing, and this is pretty much any time I have discussions like this, is the first thing we have to define is, what do we mean by exercise, and then what do we mean by the application of that? So, are we talking more of a public health kind of perspective? Are we talking about specific rehab perspectives, sports performance? All these myriad things. One of the big things I think people forget about exercise is the mental health component that can be at play, both good and bad. If somebody's having a miserable time with their exercises, you could actually be having a negative effect on someone's mental health. But again, always kind of exploring what are all these different ways, because a lot of times when I see disagreements happen is that one person's thinking of it in one context, and another person's thinking of it in another context, and they're arguing points that have nothing to do with each other and think that they disagree. And so, we'll kind of explore that a little bit and just try to set the stage of some of these conversations of, whether or not we're doing enough when we have decided we want to intervene with something like exercise, whether or not we're doing the appropriate, actually doing the thing we think we're doing, or if we're doing something else entirely.
And we both sort of quite liked the title, perhaps, whether we draw it into the title, but it's certainly that the direction of travel will be reforming our relationship with exercise, and so what we're getting at with it, and why, if it should be at the core of what we're doing, or a core component, then why and what, and trying to make sure that we take a proper deep dive into that. So I'm really excited for that session and looking forward to your thoughts on it. Before we go, is there any way you would like to point people to your various different resources and platforms? You can't plug your podcast on her. We need all the listeners we can get, but everywhere else, of course, you can talk about.
Yeah, also the podcast isn't that great anyway.
Well, you can say that.
Yeah, if you just my website, thesciencept.com, pretty much has any way you can find me. The other websites I'm involved with probably all kind of filtered through that. Any of the courses that I teach are available on that website as well. And then I occasionally we'll write some blog posts. There's definitely a big history of blog posts there. Sometimes they'll email me, hey, why don't you write about this? Like, cause I wrote about that like 5 years ago, just go read the post. So there is kind of an archive there that people can definitely dig through. And there's links to not to plug the podcast, but there's links to, the main one that I do is PT Inquest, which is kind of a journal club where we just talk about an article and what it says, what it doesn't say, how to apply it, how not to apply it, giving suggestions, and helping people become better critical thinkers.
Yeah, I mean, it still breaks my heart a little bit, but Jack March, who is our rheumatology lead at Choose Health and very involved in the podcast, pretty much heads up the podcast now for us. He still names PT Inquest as his favourite physio podcast, which just absolutely breaks me every time. But yeah, it's certainly a really nice deep dive into a particular paper or cluster of papers sometimes that goes into the bare bones of it. And he is the science PT, and he makes sure he does it in a scientific and methodical way. Certainly get more from him there than you do from me with my waffly questions. So thank you so much for your time today, mate, and I really appreciate it. Really looking forward to seeing you in October, and make sure that the rest of you get your tickets to that. It's going to be a great event and great party, so I look forward to having a drink with you then, mate.
Thanks. I'm looking forward to it, and thanks for having me on the show.
No bother.
So there you have it. I hope, like me, you found that really useful. It's an area of the body where I feel, on occasion, my clinical reasoning and anatomy knowledge has let me down slightly in the past. Those younger hips that come in, a bit more difficult to assess, a bit more difficult to manage. Really useful getting all that information on how the biomechanics and the psychosocial aspects of the patient's presentations can really affect how they get symptomatic from what is really quite a common morphological difference in the hips. So again, I hope, like me, you found that as useful as I did. Great thanks to Erik for taking the time out to support a podcast that is not his own. As usual, got to give kudos to Jack for the really excellent questioning. I mean, as part of a team, obviously he's supported by the rest of us. We come up with the questions, he's just the mouthpiece, but he delivers that mouthpiece really quite nicely, so claps to him. Social media wise, follow Erik Meira on Twitter. He's at Erik Meira, Erik spelt with a K, Meira Meira. You can find Jack Chew at Jack A Chew. The podcast team tweets from at TPM Podcast. If you're interested in following me for rheumatology based stuff, then I'm at PhysioJack. Please remember that all of these podcasts are completely free. If you can chuck us a few pounds on Patreon, then just go to patreon.com, search for the Physio Matters podcast. You can sign up for as little £1 a month. That really helps us keep us going. All these server issues that we have on our website keep going down, all this sort of stuff. We need the money to keep keep this thing ticking over. Without those donations, really, this show would not be anywhere near like it is now. And I can't stress that enough. We've had conversations in the past about whether we can even continue the show or whether we need to drop it from a monthly show, or, you know, all these different things have been put on the table, and we've managed to keep up these monthly recordings and putting these podcasts out for you consistently for now 55 episodes, plus or minus some bonuses. So absolutely can't thank those patrons enough. They really keep us ticking over and keep this show on the air. Remember to sign up for the conference. Keep your eye out for more competitions on our social media feeds. We've given away 4 course places this year, including one place entirely for free to our conference. We've got at least 3 more that I know of coming up this year, so keep your eye out for those and enter, and you could really win yourself some even more free CPD out of us. Once again, I've been Jack March. I really hope that you've enjoyed this episode, and we'll see you next time for episode 56 of the Physio Matters podcast, as we get into our late middle ages before we become geriatric. I've just finished watching the football, and all I've got left to say is it's coming home. Sorry to you non-football fans out there, but we're all football fans here, and it is coming home. See you next time.
You've been listening to the Physio Matters podcast, discussing physio matters because physio matters.